Herd. How you doing?
Always good.
Good. Here to do another news roundup, and we have a number of stories that are in the headlines over the last month or so. I do want to do one shout out. Herd, you and I just did our year in review podcast with Blake and Cleet and Anna, and that's out now. So hope everybody can take a listen on that. That's on YouTube and then all of our streaming platforms. That was a good one though, right, Herd?
It was a lot of fun. We had Blake Madden of hospitality fame and his dad. So it's a good, lots of good stories, good conversation. And I think Blake will be releasing it on his podcast platform next week. So
Yeah.
pretty exciting.
What's that one called? Claims Denied or something
Claims
like that?
Denied, brand new
Yeah.
podcast. So
Yeah.
always good.
I'm sure it'll be great. Okay, well, let's get into our stories. We've got a bunch today, but there's some quick hitters, Heard, and so there's 8 or 10 pretty good stories, and then we'll end with two kind of meaty ones around M&A activity in 25. The first one got Wall Street going, and it's around the 27 Medicare rates. And it looks like CMS is going to hold steady on that with a 0.09% increase. And that sent all the big payer stocks, publicly traded stocks, tumbling the other day. Any thought on that, Herd?
Yeah, I think we saw United stock down quite a bit. I think the expectations were for like a 5% increase, and basically it held even. And
Yeah.
so, and this is for the rate that insurers receive for Medicare Advantage patients, I believe. And so that was a kind of a shock, and we'll see what happens and where it goes from there.
Yeah. It's just so interesting how Wall Street reacts when something like that happens. The second story is really on healthcare fraud. Healthcare fraud is a huge problem. So President Trump has come out with this is a new strategic priority for he and his administration. They're talking about just billions and billions of reclaimed funds that they're going to get over the healthcare fraud that is at pretty epic proportions. That's probably something we need to dig into deeper, Herd. It just seems like that is a really, really big deal going right now.
Yeah, it's a burgeoning topic. I mean, we've been talking about it's one of those perennial issues, I think, that comes up quite often. I remember President Obama talking about waste, fraud, and abuse. It keeps coming up, and I don't think the problem's gotten better. It's one of those that I hope at some point, if we can really make a dent and get it. But an interesting story. It's always there. But hopefully we can, with technology, with some attention, you can actually have some true recovery and squeeze fraud out of the system.
Hey, maybe AI can figure this one out.
Yeah.
You never know, right?
It's figuring everything else out. So stick it on the.
Just let ChatGPT go. And just find all the fraud. Get rid of it. It may not be that easy. The next story was kind of interesting, and it's about really cybercrime, something that's more and more in the norm than, call it even 5 years ago when we thought, phishing and cyber attacks, that's just sci-fi. Well, it's not sci-fi anymore. And so there's over 75 health systems across the U.S. This is in a Fierce Healthcare article on January 29th that talked about these 75 health systems have come together and said, we really need to band together and watch out for where our data goes, where all of our healthcare data goes, and all the apps that are tapped into their EMR and their billing systems and all that. There's too many kind of holes in the dam as far as the ability for bad actors to get in. I mean, what do you think about that, Herb?
Yeah, I mean, as we've moved, medical records online, electronic medical records, I mean, that's been pushed over the last 15 years. And then as technology has gotten to a place where we now have all this data, it's very helpful, very useful. So we have vendors that are, tapping into it, using it. There's a lot of, compliance around data sharing with HIPAA, and hospitals and health systems have large compliance teams, and they want to make sure they're handling it correctly. But I think this is a case where the technology and the amount of data is just, moving faster than the processes and the ways to secure it. And so I think we need almost a rebalancing of that, because there's so much data out there. It can be very useful, but because it's there, it can invite bad actors. And we've seen lots of cyber attacks in the healthcare industry over the last 5-6 years, and it can have some real consequences. So I think this is needed, probably a needed rebalancing, and some attention should be paid attention to.
Yeah. I just like how the health systems are kind of they're taking matters into their own hands.
Yeah.
Like that. The next one is it's an interesting article out of the Wall Street Journal on January 26th. It says health insurance is now more expensive than the mortgage for these Americans. And these Americans are talking about early retirees, independent contractors, and small business owners. Mm-hmm. So if you're out trying to get your own health care, if your company doesn't provide health care insurance for you, and you're a early retiree or an independent contractor, whatever. And it says that the average for cost of that was, this is hard, this is mind-boggling, $888.25, and it's going up to $1,904.26. So over doubling for these poor people. I mean, that's awful, right?
Yeah, I mean, individual health insurance has always been more expensive. I think a piece of that and part of their equation that they're baking into those numbers is the expiration of subsidies on the exchange. So the Obamacare subsidies for exchange plans, that was a big issue that drove the government shutdown back last fall. I think it's still an issue that's going to come up. And really stories like this and this issue, I really think healthcare is going to be a big item in the midterm elections. And I think for sure 2028, we're kind of back at one of those inflection points where this item and this cost of living issue related to healthcare is really bubbling back up, and it's going to have some electoral implications, I believe.
I think you're right. The next one is right in your wheelhouse, Herd, and it's talking about how this is a KFF Health News article on January 26th, and it's talking about how more and more hospitals are owning their own Medicare Advantage plans. And so Herb, that goes back to you because you do a ton of managed care contract renegotiations for hospitals and docs. Why would this be attractive to a hospital?
I think this, again, probably having vertically integrated and kind of full control of the healthcare dollar. And I think, they see this as a way to have more control over that dollar. And with Medicare Advantage, you see a lot of those plans, the way they make their money is, denying claims, slow paying claims. It's a little bit different than standard Medicare. And so I think this maybe gives the health systems a little more control over that velocity of the dollar and help them, alleviate some of those revenue cycle problems that they see with Medicare Advantage. Now, whether or not they can do that and still be profitable and does that make sense? Probably need to dig into those details a little bit more before we really understand it.
No, I get it. It's still, I think, a very, very small portion of the overall Medicare Advantage pie, or certainly traditional Medicare. But we saw the balance between the two hit in 25. And then now the portion of the Medicare Advantage plans is growing. It's still very, very small for hospital-based, but it is.
Yeah, but Medicare Advantage in general, I mean, that crossed the line where more Medicare enrollees are on Medicare Advantage plans than traditional Medicare. That crossed the line last year or year before. And so as a percentage of the total Medicare population, Advantage is a big component of it. So I think what you see is you got some hospitals trying to be creative and figure out how can we optimize, within this system, within the way things are moving, how can we optimize it? And maybe this is a way to do that.
No, that's right. There was an article in Medical Economics on January 20th, and this is pretty complex, but it's something you and I have been tracking because we have a real heart for independent physicians. We do a lot of advisory work for independent physicians all across the country. And in this, it was just talking about the trend for how hospitals are employing doctors. And in that, it was shocking. Between 2019 and 2023, the share of physician practices owned by hospitals, health systems, and other large corporate entities rose from 39 to 59%. And there's a lot of, in this article, there was a lot of talk about how the prices increased from those independent physician shops to, you're going from kind of OBL or clinic-based to HOPD or hospital-based pricing. And so there was a real delta between those two prices. The shocking thing to me was just the rapidity of how quickly things are shifting over. So when we talk to our physician clients, our independent physician clients, and they're like, "What do you think, Al? What's it going to be?" I'm like, "Oh my gosh! I mean, who knows?" But this is the way things are moving very, very quickly, right?
Yeah, I think this speaks to the economics and the difficulty of independent physicians. I mean, this is happening because people are responding to incentives that are out there. And one of the incentives is it's very difficult especially for primary care, family medicine, small groups like that, to be an independent physician or a small physician group, it's really difficult to make it.
Yeah.
So you see, this is one of those things that's driving it. You see a lot about the increase in the cost shift that happens when they become employed, and the increase in reimbursement. I almost think that speaks more to the low reimbursement in the independent setting, how it's not economically sustainable, and that's driving people towards this. So a lot of people say, well, the prices are increasing too much. Well, the data and the human behavior is clearly showing that you can't make it, economically on your own. And so maybe the prices on your own are too low is another way to look at it.
That's
Probably
right.
not a super popular opinion, but I'm just looking at the data and looking at what behavior is indicating.
Right, right. Well, you and I have talked about how provider collaboration, whether we like it or not, is a must because they just don't have the power that the payers do in many chances when you and I go back and follow the dollar. A lot of times collaboration is just required for financial viability. The last two stories, let's hit on those real quick, but they're good ones. And it's really talking about the M&A front. And then the last story is around PE activity in 25. You and I are about to get on an M&A update with our CFGI buddies. And so we'll make this short, but in that we're going to go deeper into 25 and then what we see in M&A activity for 26. But there was this fantastic article that Hall Render put out on January 20th. And it was really about just the overall trends in healthcare transactions. It articulated 8 different cohorts for what those were. And let me just real quick highlight those. Non-core asset carve-outs where, non-hospital related stuff, they're just carving them out and get rid of them. Then antitrust enforcement and federal policy considerations. That's still a big deal with antitrust. Real estate trends. What do you do with your real estate with rising costs? Private equity, where it plays, ASC transactions, rural health, pharmacy, and the AI impact. I thought overall these 8 cohorts of issues were a really nice way to frame up the M&A activity. We'll get into this deeper, Hurt, but any initial thoughts on that?
No, I think we're seeing M&A activity pick up again in 25. I think a lot of that activity you see is addressing real problems, trying to, and I think that's a nice way to frame it, kind of within those cohorts. It's like, what problem are you trying to solve, or what's the reason for the acquisition? And I think it's a nice way to frame it, and look forward to talking more about it.
No, I do too. Again, we'll get on with our CFGI buddies here in a couple of weeks and get that going. The last one is just talking about private equity. Everybody's like, oh, private equities, they're everywhere. Well, sometimes they are, sometimes they're not, but their activity load really picked up in 25, where we saw over $191 billion in 2025. And it says that was really around biopharma and provider. Biopharma, 80 billion, and then provider, 62 billion. So those are their 2 big buckets of where they're focusing their efforts. And we have seen a lot of that activity with the QV work, with the financial advisory, with the diligence work that we're doing. There's a lot of PE investigations. Sometimes they close, sometimes they don't. But regardless, we're seeing a lot of activity on that front.
Yeah, I think that's going to continue to be a story in healthcare. And I know there's different opinions on that, but I think PE provides a capital source and it's going to be there. So it's certainly something that we see and we work with all the time.
Yeah. Okay, Hurt, that's our top stories for today. Appreciate you being with me.
All right. We'll see you in the next one.
Okay. See y'all.